Hello everyone, welcome back. So today this is the last ECG video we'll make. Okay, I'll discuss two topics here: hypokalemia and right ventricular syndromes. Okay, so let's start with it. Okay, so hypokalemia. What are the ECG changes that you will see? First is U waves. Okay, so U waves is very important. What is U wave? U wave comes after T wave. This is also again I have discussed before. After T wave, you will see this. Okay, there will be small or absent T wave. Occasionally there will be inversions. Okay, there are two intervals. Remember, PR interval and QT interval. Okay, so there can be prolonged PR interval and there will be prolonged QT interval, and there will be ST segment depression. So ST segment depression, T wave inversion or absence of T wave. Okay, or it can be there will be a available, you can see U wave. Okay, so new waves will appear, that will be U wave. Okay, so prolonged QT interval, what some authors also say that actually it is not true prolonged QT interval, because U wave appear after T wave and T wave disappears. So what happens is it appears like there is a prolonged QT interval, but it actually means that, for example, here in the ECG we'll see, if you can see, there is a ST segment depression here. Okay, this is ST segment depression here. Okay, as you can see, there are no T waves here, and this is actually U wave. So this is called pseudo prolonged QT interval. Okay, so this is what some books tell. Okay, and this prolonged QT or QU interval means there is some interval that has increased, and it's a possibility that it can lead to polymorphic ventricular tachycardia. Okay, that is called torsade de pointe, polymorphic VT. So that's why it is an emergency and you need to treat hypokalemia properly. Okay, so this is the importance of it, because it can lead to ventricular tachycardia and ultimately death. Okay, so these are the ECG changes, easy to remember. See here also, as you can see, this is actually showing T wave. This is T wave inversion with ST segment depression. Both are depressed, ST segment and T wave. Okay, and this is U wave. Okay, this is U wave, this is T wave, and this is ST segment depression. Okay, so it is a very good ECG to understand that. Okay, now what is U wave? Prominent U wave. U wave, it can be normally present in some leads. Okay, if it is more than 1 mm or it is at least 25% of the height of the T wave, then it is called prominent U wave and it is abnormal. It is most common, two common causes is bradycardia and severe hypokalemia. Okay, these are the two important causes as we have discussed. There are rare causes, so remember hypokalemia, hypocalcemia. Mostly the ECG changes for both will be same, but this U wave is rare in hypocalcemia, then it is hypokalemia. Hypomagnesemia, again hypomagnesemia can lead to hypocalcemia, can lead to hypokalemia. Hypothermia, raised ICT, left ventricular hypertrophy, and HOCM. Okay, so this is, and one important cause is digoxin. I just added this because it is an important drug. Okay, now this you can see, this is your U wave. This is your U wave. After T wave, this is your T wave. Okay, so I hope this is clear. Okay, so now we'll discuss hypothermia. Okay, so hypothermia ECG changes, most important is this Osborne wave. Okay, Osborne wave. Okay, so as you can see, this is a J point. J point is a junction between ST segment and S wave. Okay, so this is a junction that is called J point, and in hypothermia you will see this small deflection, small positive deflection. Okay, and also there is mild ST elevation, and this is called Osborne wave. It is very classical for hypothermia. Okay, so now we'll discuss RV syndrome. There are two important syndromes that I want to discuss here. Okay, first is Brugada syndrome. Oh no, first is ARVD. Okay, what is ARVD? It is arrhythmogenic right ventricular dysplasia. Okay, it is a dysplasia of right ventricular wall where myocardium is replaced by fibrofatty tissue. Okay, and it leads to arrhythmias. Okay, there is one classical wave that we see here is epsilon wave. Okay, it is again a positive deflection, but remember I told you hypothermia will also have a positive deflection. It will be at the J point, and in ARVD this positive deflection will be at the end of QRS. Sometimes it is also seen in the ST segment. Okay, at the end of QRS or in ST segment or on ST segment. So it looks like ST elevation sometimes. Okay, so this is an important one. It is an autosomal dominant disease. There are also autosomal recessive variants. Second, I want to one more important is Brugada syndrome. Okay, so Brugada syndrome is again autosomal dominant. Okay, it is a channelopathy. So sodium channel 5A gene mutation is there, and sodium channel cannot work properly. Okay, and it will lead to some changes that we'll discuss. There are three types of Brugada syndrome. Okay, so as it is a right ventricular syndrome, V1 to V3 of V1 to V3 leads on ECG will show the changes. This is important to understand. Okay, so see, as you can see, this is an Osborn wave on J point. This is on the J point, J junctional point. Okay, this is an epsilon wave. Okay, and this is a delta wave seen in WPW syndrome. So these three important waves are very classical for the diseases. Okay, so Osborn wave. Where do you see hypothermia? This is ARVD and this is WPW syndrome. Okay, I have already discussed WPW syndrome in my previous videos. Okay, so now Brugada syndrome, it is an autosomal dominant syndrome. Okay, autosomal dominant syndrome. So as I told you, there are three types. So most important to understand these three types is, okay, there will be ST elevation. Okay, there will be ST elevation. So actually J wave amplitude is ST elevation. So in type 1 it will be, in type 1 in all the type there will be ST elevation. Okay, so J point, as you can see, type 1 in all this is a J point. Okay, this J point is elevated, it will be more than or equal to 2 mm. Okay, now the configuration of STT like ST segment. Okay, so it will be curved, like that will be convex. Okay, as I discussed in STEMI video. Okay, it will be like STEMI. Okay, here it will be like a saddle back. Okay, so remember, saddle shaped ST elevation with global ST elevation is seen in pericarditis. Saddle back is seen in Brugada type 2 or type 3. Type 3 can be both, either curved or either it can be saddle back. Okay, saddle back, as you can see, this is what we call saddle back. Okay, here it will be, ST will be elevated. Okay, so J point will elevate and the end point of ST segment will go will be gradually descending. Okay, so as you can see, it will be gradually descending. This is type 1. In type 2, it will be the ST segment will be elevated. J point will be elevated more than 2 mm and there will be a saddle back shape, and the last point. Okay, as you can see, this is the last point of ST segment. Okay, it will be at least more than 1 mm. So difference between type 2 and type 3, if it both are saddle shape, okay, saddle back shape, then the only difference is the end point of ST segment is more than 1 mm and here it is less than 1 mm. As you can see here, this is actually the final part of the ST segment will actually not be elevated, it will be near the baseline. Okay, so this is how you differentiate type 2 and type 3. And again, one more differentiation is T wave. Okay, so T wave in type 1 will be negative. Okay, so remember, type 1 ST segment, the J point is elevated more than 2 mm. The last segment of ST segment is decreasing gradually, and that there is T wave inversion. Okay, in type 2 it is a saddle back. Okay, so saddle back, but the end point is more than 1 mm. ST segment is saddle back, the end point is more than 1 mm, and T wave can be either biphasic. Okay, what is biphasic? Okay, this is your baseline and this is a biphasic T wave. Okay, and or it can be positive. And in type 3, the last part of ST segment will be less than 1 mm and T wave will be positive. Okay, so this is how the other two findings you will see. The other one finding you will see is RBBB. Okay, there will be complete or incomplete. More incomplete RBBB can be seen in Brugada syndrome. Remember, V1 to V3 leads you have to see. As you can see here, V1 and V2 are showing ST segment elevation. Now, investigation of choice for this is, so what happens if you are suspecting Brugada syndrome, if a patient comes to you with mild ST elevation and if you are suspecting Brugada syndrome, if there is any family history, what you do is you give flecainide administration. Okay, if flecainide, after giving flecainide, this ECG changes become more apparent, more prominent, and that's how you diagnose Brugada syndrome, and it is an investigation of choice. This is a very important MCQ question. Okay, so thank you so much. If you really learned from my videos, please like, share and subscribe. Okay, this is the end of my ECG lectures. Thank you.